We'll move on to our next speaker for the purposes of time. Dr. Raj Basu will be presenting virtually, leveraging personal health platforms for AKI follow-up.
Hello, everyone. Can you see me okay? Yes. All right, nice. Let me share my screen. Okay, it's kind of ironic that I'm talking about mobile health, and here I am presenting virtually to you. Thank you to Dr. Mehta and the organizing committee for inviting me to speak on mobile health, DHI, personal health record, EMR, AKI, CKD follow-up, otherwise known as alphabet soup. And so we're going to go through the next 12, 15 minutes and really understand how mobile health might be able to be used for personal health improvement. Just some minor disclosures. Wanted to make sure everyone, I'm wishing you a happy Pi Day. And I will tell you that a majority of my mobile health is dictated by my kids who are asking me for more TikTok time. Why do we care about this? Well, this data is now 10 years old, but almost everyone in the room probably has seen it, that nephrology follow-up improves all-cause mortality of severe AKI survivors. So in this Canadian cohort study of close to 500 patients, what was found was a reduction in all-cause mortality simply by seeing a nephrologist. The details were not clear as to what was done, but any cause mortality was reduced up to 3 years out. And you can see that the mortality reduction actually happens early and it persists over time. And it actually increased in patients that have higher risk, diabetes, for instance. On a breakdown of the study, what was demonstrated was that people who did not actually have nephrology appointments before or nephrology involvement before did better. And then again, if you see how this spread between the light blue and the purple, this spread started early, within 30 to 60 days of follow-up, and then spread along 6 years follow-up time. Why would this be, though? Lost in transition and an understanding of what are driving the poor outcomes of AKI is important. The tail of the tape is pretty clear. In patients with CKD, if you look at Medicare data, only 23% of patients with Medicare actually have follow-up appointments with nephrology. Patients with diabetes, only 1 in 3 almost. And this interrogation of this Medicare database was done using the most severe forms of AKI and the CPT coding. A parallel study using the VA system and actually adjusting for competing risk for MAKE also demonstrated very low nephrology follow-up rates. Who got kidney support therapy and nephrology follow-up in England? Very small percentage of patients. In provincial Canada, also a small proportion, less than 50%. What's demonstrated, however, is that there might be some signal to understand what nephrology follow-up and an AKI follow-up clinic could possibly do. In this follow-up study done by the same group in Canada, demonstrated there was a reduction in cardiovascular events and death and increase in cardioprotection meds that were done when in-person standardized assessment with the nephrologist was done to discuss kidney complications, cardiovascular risk, sick day labs, and quarterly labs. This is important because if we look at the number of dollars spent in healthcare money in the US, we're looking at the adjusted increase of dollars of billions and billions in relation to CKD patients and end-stage renal disease. When this is broken down, what we find in this histogram plot where we compare patients who had no previous kidney disease in the dark blue dotted box to the other, which is the light blue dotted box, to the slash box of chronic kidney disease, see a majority of the mean expenditures come from inpatient. But one would ask if you can change the outpatient landscape so that inpatient readmission numbers go down or office-based visits increase so inpatient admissions go down, you may actually be able to make a real dent in the healthcare expenditure market. Yesterday, as Dr. Mehta mentioned just now, Dr. Angus spoke wonderfully about this idea of phases of care and this allegory of the looking under the lamppost, that we look under the light for the keys that are not there because we think it's easier to find them, even though we should be looking in areas we haven't been before. Sepsis is the best example. In thinking about using digital health solutions for things like this, can we use artificial intelligence? Can we use health information technology or mobile health or digital technology to overcome our barriers to understand awareness and communication? Sepsis detection is a big market out there. So mobile health sensors are actually widely deployed now in many ways. The sepsis detection market is funded to the tune of $40 billion US per year. Phase 1 detection study actually has been focused on understanding sepsis in the pre-hospital phase and pre-antibiotic phase. So while we are good at once they come to us, this pre-hospital phase is important, but the issue with it is that post-sepsis follow-up causes a huge morbidity on the system. Just like AKI, 40% of sepsis survivors face the risk of readmission, and comprehensive care transition processes can lower this risk. So there are patient engagement tools like this one shown in this phone. It's called Twistle by a company called Health Catalyst. Twistle is really an SMS messaging system that can be adapted for your own personal needs as a physician to be in touch with patients and their families. Here's an example of a screenshot from Twistle that allows for automated messaging pathways. And you can tell that the questions that are being used in this mobile health platform are really about, well, hello, Eloise, do you have a wound infection or not? But you can also use this to look at check-in days, medication reminders, how to manage your pain, etc. ARDS is not immune to this battle. The healthcare utilization and costs in ARDS are significant. 1-year longitudinal data following up from ARDS admission shows that a high readmission rate is a big problem in this patient population. And this is a big focus, not just in following up in their mobile health scores, but using follow-up care, including mobile applications, to understand functional status score, and this is the bottom right, psychiatric symptoms, and physical therapy. So what these applications are using in the follow-up from ARDS is simply saying, if you're tracking this stuff, are you coming into the hospital more? And obviously what they're finding is patients who track this information, patients who engage in mobile health technology, actually are more invested in their chronic health features. Mobile app and digital systems are being used for follow-up in myocardial infarction. This is an after AMI study that's being piloted now. This is a study design that's published in Trials a couple years ago. It's a mobile health platform for post-AMI care. The intervention is a mobile app that has reminders of education, vital signs, medication reminders, history cards, how to get a hold of your healthcare professional or your primary care doc, and actually make sure that you have routine labs that you enter, whether you're following your BMI or your lipid levels, or if you're smoking, et cetera, and it ties it to readmissions. Has any data been found in this? Well, actually there has. So the MyCore study, which was published a couple years ago, using this MyCore health digital platform, which is a combination of an Apple Watch, a blood pressure monitor, and a smartphone app, which then downloads or sends information through the cloud to secure-based web service. It looked at the intervention of just this app to track your medications, track your blood pressure, et cetera, and how it related to readmissions. And what we can see in the histogram here is that the DHI group, which is cohort matched to the control group of 1 to 4, demonstrated a pretty significant reduction in 30-day all-cause readmission, down to 7% from the baseline of 17%. And you can see how this spread starts within 5 days and persists, and it gets wider throughout 30 days. So clearly, people are using this in follow-up from critical illness recovery to help reduce readmissions and complications. So in AKI, can we use mobile health to connect the what, the who, the when, and the how? Well, it seems like the right thing to do because these cases always exist. A veteran who lives a long way from a VA medical system needs nephrology follow-up because he has CKD. He receives his primary care at a local VA community and he doesn't want to see a specialist. He thinks he should be able to use a computer. He'd rather use that system than have his son drive him to the VA medical center. Another one, a younger woman who's admitted after a crush injury in a car accident, has AKI. The nephrologists at the hospital are uncomfortable with the technology, but need consultative help. So the family doesn't want to send her out there. And shouldn't it be possible to care for patients like this? Well, as every nephrologist in the room knows, there's a big discrepancy of where the patients are and where nephrologists are. If you're in Montana and you have a kidney issue, God be with you, and the rest of the Great Plains for that matter. But you can see the far and wide spread, and these are dots relating to training programs of kidney service training, nephrology fellowship programs, and how many ESRD patients exist per nephrologist in the geographic boundaries. So a big discrepancy that has to be overcome. So the AKI 27 group took on digital health as the idea of how do we actually approach AKI using this perspective of digital health. And in this paper, it was very much a perspective paper to understand what can we do with community applications for risk stratification, recognition, and guiding AKI recovery? What can we do for post-acute care applications? And not just about acute care applications, because to use Dr. Angus's analogy, the acute care applications are very much under the light. The post-care acute care applications are not. How do we use recognition? How do we tailor the response? How do we guide AKI recovery? Well, there are digital tools out there to use artificial intelligence, digitally enabled therapeutics, mobile health applications. And what this allows people to do is to make it patient sensitive, patient specific, patient dynamic, and patient driven. And all of this can be used through a combination of both telehealth and virtual care, but mobile health applications and wearable sensors and devices. We just haven't pushed go on this yet. So as we're at this conference talking about the greening of ICU, we really should be talking also about how to make it green using digital care. So is there evidence of utility of digital healthcare for AKI management? There is evidence in the inpatient study, as their consensus statements indicate. But in the post-AKI, monitoring of kidney health and AKI survivors may help for reducing progression in the ambulatory settings. And actually, what is needed is more exploration in the AKI aftercare. Mobile health has positive effects on medication adherence and safety. There are wearables for blood pressure monitoring, volume status, oxygen saturation, urine assessment, and these further studies could be DHAKI focused. Some examples of what's been done, and this actually, the best examples of these kind of platforms come from nationalized healthcare systems such as exist in Korea, in Canada, and the NHS. The SCAN ECHO curriculum to help guide communication between a nephrologist and a PCP to discuss diabetic kidney disease, proteinuria, the importance of thinking about anemia, thinking about glycemic management, all these things that the primary care doctors should be able to do. They just need some guidance from nephrology. These are initial studies that are out there, Metasafe BP, looking at medication adherence, something called SMART-D, which was a dialysis home monitoring program and really focused on a mobile health platform and thinking about ease of use, talking with a social worker about kidney donation, using a medical app that actually received positive vibes. And, it's not that difficult to understand the who either. This is a JTCVS paper discussing cardiorenal syndrome and cardiorenal crosstalk and post-cardiac surgery AKI. We are aware of this issue in the AKI to AKD spectrum. And awareness doesn't mean we've tackled this, of course. But what we should be really thinking about is these patients have significant AKI to CKD risks, greater than 90 days post-injury. These are the patients who are known to have heart failure at 3 months post-surgery. Dr. Shaw gave a wonderful lecture yesterday about the unhappy right ventricle, adverse outcomes about death, new dialysis, and heart failure. So we know who, and we know when. And actually, we have toolkits that may tell us how. The Royal College of General Practitioners, and this comes from the UK, has laid out wonderfully in nice color-coded format the different degrees of AKI stage, the timing of what should be done if you go left to right, blood test monitoring, urinary albumin creatinine ratio measurement, how to think about kidney recovery, and how to actually think about risks for the patient. You have to be thinking about social context. You have to be thinking about tailored and timely reviews of the patient, accurate discharge and handover. And this is where the intensivists come in. Because, as an intensivist, we must be coding correctly. We must be communicating correctly with our collaborators and colleagues. And we must be educating the family correctly in the sense of what is actually significant related to the AKI. We have a heavy hand to play when it comes to optimizing drugs. Were drugs stopped or altered? Were they restarted and turned back to where they were? Do they need to be readjusted? What about adjudicating the presence or the new presence of heart failure in the setting of AKI? And so when we think about coordinating monitoring of kidney function, we do think about, are these patients who have AKI, how much of a risk are they for progressive CKD? How much are they going to be using the healthcare system? How much is the risk for readmission? what could be done to prevent this in their own hands. Because the more you make it patient-driven, particularly in this way for kidney health, the better it would be. So we know what things to do. So we kind of know who, we know when, we know what. The question is how. How do we tackle all this? Well, I started with this alphabet soup, so I'll end with my own alphabet soup. This is my own ABCDEFG for care after AKI. And this is a calling to all of us in the room, and I'm sad that I'm not there to see all of you, but A stands for awareness. We all have a role to play. We all can do better to make sure there's awareness related to post-AKI management. We all can understand the B, the barriers. It's our job to identify ahead of time what could be a problem for this patient and family in relation to getting the proper AKI follow-up care, whether it's socioeconomic status, whether it's a language barrier, whether it's financial, whether it's distance, whether it's access to mobile technology. We must communicate with each other. This does not happen in a silo. And, when in the adult world where there's 6 different ICUs, that makes it pretty challenging. I can only imagine how difficult it is to be Michael Connor, to be rotating through all these different ICUs and being able to navigate surgeon and cardiologist and other collaborators in this way. We must be thinking about how to use mobile health and smartwatches for our benefit. So many in the room wear Whoop bands or use smart iPhone apps and think about their heart rate variability, think about their sleep quality. These are things that can be done and be used to develop nephrocentric health follow-up. Drugs. All of us have a role to be thinking about this in the right way, especially in AKI follow-up. And of course, pharmacists for the win every single time. Nothing is more important than E for education. And it is also important to think about not just barriers, but what will make things fail. Why would a patient fail? What is the slow step? What will be preventative of AKI follow-up? And nothing for an intensivist speaks louder than what the goals of care are. What is the code status? What do patients want for dialysis? If no one's talked to them and they have CKD, but maybe they don't want dialysis, but they come back in for readmission and no one would have told them, well, you're not is this something you want? They wouldn't be coming back in. What are the lines in the sand? Home dialysis, transplant, social work, psychiatry. And let's not talk about money. Let's not use money as an argument, because this is data from JP Morgan looking at the revenue generated in the health app sector. So if you know anybody who knows how to develop mobile health platforms, they stand to make a lot of money in this. And you know what? We could do better for patients too. So personal health platforms can be used. These are some very easy ways: heart rate, blood pressure, urine output, telehealth, reminders, and alerts. And ABC to EFG to prevent AKI to CKD and reduce mortality. A little limerick to end Pi Day. Thank you very much, and I really appreciate the chance to still present, even though I myself am in a mobile health platform right now.